Good afternoon, everyone. We're just going to get started here in a moment. Hey, we are at the top of the hour, so we'll go ahead and get started. So, good afternoon, everyone, and welcome. I am Jennifer Muthig, Executive Director of the New York State Association for Rural Health, and I'm excited to welcome you today to our webinar, The Fourth Trimester Postpartum Care in Rural New York and the Health of Birthing People. I'm really excited to have with us today Ava Thur, our incredibly talented NYSAR intern this summer with the Upstate Institute Summer Field College at Colgate University. Today's presentation will explore the unique challenges that rural birthing people face during the postpartum period, often referred to as fourth trimester. While much attention is given to prenatal care and childbirth, the weeks and months following delivery are a critical time for maternal health and well-being. During today's webinar, we will discuss barriers to accessing postpartum care in rural communities, the impact these barriers have on physical and mental health outcomes, and why improving access to ongoing postpartum care is essential. We will also examine current gaps in the healthcare system and consider opportunities to strengthen postpartum care for rural families. So thank you for joining us today. Before we begin, I'd just like to share a few coping opportunities from NYSAR. Registration is now open for the 2026 NYSAR Rural Health Symposium taking place September 17th and 18th in Clayton, New York. The symposium brings together community leaders, healthcare professionals, policymakers, educators, and advocates from across New York State to share innovative ideas and best practices for improving rural health. If you haven't already registered, we encourage you to secure your spot today. I was told this morning at our symposium planning committee meeting, we have 2 exhibitor tables left and a couple other sponsorship opportunities if you're interested. Sponsorship is a great opportunity to showcase your organization, connect with rural health leaders from across the state, and support the advancement of rural healthcare in New York. Our next educational webinar will be in October soon with Ruth Ann Craven from HCSCNY, focusing on bridging the gap using HCSCNY data to power 30-day transitional care. Janai is going to go ahead and drop that link in the chat if you're interested, and we'd love to see you attend. As always, feel free to reach out to me with any questions, comments, or suggestions you have to make our teams a better place. And with that, I'm going to turn it over to Ava.
Okay, hi everyone. Thank you for all joining me today on this Thursday afternoon, and thank you, Jennifer, for that introduction. I'm just gonna share my screen and then we can get going. Okay, so today I will be talking about the fourth trimester, barriers to postpartum care and the health of birthing people. And this webinar kind of encapsulates my past 10 weeks with NYSAR and the research that I've been doing regarding postpartum care and all of that, all that encompasses. And so I think there will be a couple minutes at the end for questions, but if anyone has any lingering questions, if anyone has anything that you think I might have missed, any feedback, that would be greatly appreciated. My email is just right here. I can drop it in the chat a little later on, but this is as much a learning opportunity for me, just as much as I hope it is for all of you. So if anyone wants to continue this conversation later on, I would love for you to do that. Okay, so now without further ado, the learning objectives. So today we will explore the significance of studying postpartum care and the systematic barriers in place to prevent rural communities from accessing equitable care. Next, we will understand the health risks, including mental and physical conditions that rural birthing people face in the postpartum period. And last, we will identify some various recommendations and tactics for the optimization of postpartum care. Okay, a little outline of where this next hour will take us is why postpartum care, who is affected, optimizing postpartum care, some New York State policy recommendations, conclusions, and then there will be some time for questions at the end. So, why postpartum care? Why is it important? Why are we talking about it? And what is its role in rural maternal health in general? Unbeknownst to a majority of people, recovery during the postpartum period is crucial in that it leads to the future health and well-being of birthing people. Without proper access and support, these issues could potentially lead to mortality. And so, zooming out a little bit and taking a look at maternal mortality rates on a national scale to begin, we must understand the context in general of what we're talking about. And so the United States has had the highest rates of infant and maternal mortality of any high-income country, despite spending the most on money on healthcare annually. And this statistic can be driven by a variety of factors, including severe racial disparities, fragmented health systems, and limited postpartum care, which we will talk a little bit about a little later on. And as you can see, according to this chart, over half, or about 53% of all pregnancy-related deaths are between 7 days and 1 year after delivery. And that statistic is even greater if you include those between 1 and 7 days postpartum. And so in 2021, the maternal mortality rate, or the MMR, peaked at 33 deaths per 100,000 live births. Now, there's no denying that COVID was a huge contributor to these statistics, but currently the MMR is about 18 deaths per 100,000 live births, which isn't an insignificant number. And as we continue on, we will look more in depth as to the causes and reasonings behind why these deaths occur and what we can do to hopefully prevent these deaths in the future. Okay, maternal mortality rate and morbidity in rural areas is, as you can see, according to this chart, is over 50% higher in rural areas than it is in urban areas. And that has been a statistic that's persistent throughout many years. Rural communities tend to be more vulnerable to pregnancy-related deaths, and as across the United States from 2011 to 2016, the maternal mortality rate ratio was 24 deaths per 100,000 live births compared to 15% or 15 deaths in metropolitan ones. And over 1/3, about 35% of these counties in the US are considered maternity care deserts, or areas without single birthing facility, obstetric unit, or any access to care in these counties. And lastly, another jarring statistic to note is that postpartum birthing people are more likely to have emergency room visits in these rural communities, with 43% of these communities reporting a visit compared to only 26% in urban ones. So these statistics are real, they're jarring, and they're sorry, and they're important to note as we continue on. Okay, so now how does this relate to our home state of New York? Within New York State, we ranked 23rd in the nation for maternal mortality rates, and in 2016, the rate in New York State was about 19 per 100,000 live births. So if you remember in the past slide, which is about average, the national mortality rate. And I understand that a lot of this information is not new to most people, especially living in New York State and dealing with these consequences. But about 48% of birthing people live over 30 minutes from a birthing hospital, compared to 4% living in urban ones. With this being the case, about 16% of counties in New York have high burden of chronic health conditions during pregnancy and a high rate of preterm birth. As you can see, according to this chart, with the distance to this chart demonstrates the distance to birthing hospitals by county, and 13 of these rural counties are in the darkest blue color, which means that the distance, as you can tell, the distance to these hospitals is drastic. And so, as we continue on, who is impacted? Who is affected by all of these statistics? And what are the health conditions? Why are all of these things caused? So I would not be accurately representing the barriers that birthing people face without including the drastic disparities between races within maternal mortality rates. According to the CDC, Black women are 3 times more likely to die from a pregnancy-related cause than white women. Multiple factors contribute to these disparities, such as variation in quality of healthcare and underlying chronic conditions. The MMR among non-Hispanic Black women was more than double the national MMR and was consistently higher than those of other racial or ethnic groups. If you take a look at this chart from 2023, non-Hispanic Black birthing people faced 50 deaths per 100,000 live births, which is a third of what Asian, white, and Hispanic birthing people all experienced. And these risk factors often exist and are exacerbated by stress related to racial inequalities and often inadequate healthcare, mistrust of health services, etc. There are many reasons and factors that can go into this, but in rural areas specifically, maternal mortality is 2 to 3 times greater for Black and Indigenous populations compared to white birthing people, and infant mortality is 140% higher for Black and 60% higher for Indigenous populations compared to their white counterparts. Okay, a few of the underlying physical health conditions. I know this chart is a little busy, there's a lot going on, but we should really be drawing our attention to the 6-week postpartum section, as well as the medium and long-term greater than 6-week postpartum section, and specifically focusing on postpartum depression, postpartum anxiety, as well as the health conditions, including cardiomyopathy and DTVs. And so the leading cause of death during postpartum period can include treatable conditions such as cardiac conditions, infections, blood clots, etc. And with the proper access and support, these all can be, or most of these conditions can be treatable. And so the trajectory of a woman's long-term health, well-being, and quality of life is shaped by her experiences during labor, during childbirth, and the following months. And so the quality of care that she receives at that time is crucial. And not only can neglecting these underlying health conditions lead to exacerbating chronic health conditions and worsening the birthing person's quality of life, but in worst case scenario can lead to these deaths. So severe bleeding or hemorrhaging increased notably by 2023, which accounted for about 1 in 6 of these deaths, while cardiovascular diseases, including hypertension complications, cardiomyopathy, are also large contributors to these pregnancy-related deaths. So next, a few mental health care barriers in rural areas specifically. I noted that there were about 3 major challenges that birthing people faced regarding mental health in rural areas, including making the decision to actively seek out that care, obtaining that care, whatever that might look like. And then once that care is accessed, there's a lack of adequate resources, providers, or access for these communities. So the first one is making the decision and taking those steps to seek that care. And parents, they typically ensure that their newborn gets care, but that might result in them neglecting their own health, especially in rural areas where there are many other factors that come into play. The next one is that rural communities tend to be much more of a close-knit social structure, which creates a reliance on informal networks, community members, all good, positive things that come out of rural communities. But even though these networks can provide a large role in accessing this care, there can also be a tendency to suppress or hide the disclosure of mental health disorders with fear of negative perceptions from their community members, from their families. And so even acknowledging that you need help is much more difficult within these tighter knit groups sometimes. And so next, obtaining or receiving that care. As you all are probably well aware, there's a large transportation barrier to accessing timely care, as well as a potential lack of childcare access, inability to take off from work, or just things in life that make you prevent your own access to your own personal care. And next, and I do understand that there are telehealth resources, there are technology resources, especially in New York State. This is starting to become more of an option, but sometimes that isn't always feasible for these members who don't have a consistent access to care or internet at all. And so the third one is insufficient mental health resources, providers, or just a lack of adequate care. Rural birthing people are less likely to receive any doctor visit in the 12 months before getting pregnant, and the screenings that they receive in the year before are less likely to be comprehensive due to all of these reasons that I mentioned before. Rural communities are 20% more likely to face perinatal depression compared to urban ones, and the consistent closures of these units and delivery units in rural communities continuously impact this access of care and create dangerous maternity care deserts. This limited access to obstetric providers is linked to increased poor health outcomes, including mental health disorders or postpartum depression, which is one of the leading health disparities in rural community. With a lack of screening, prevention tools, and absence of providers, it is much more difficult to diagnose these illnesses and to provide the proper resources in gaining and creating ongoing and supportive access. According to this chart and the CDC, close to 84% of pregnancy-related deaths in the United States are preventable, with some of the key elements such as creating a continuity of care, building relationship-centered care, or any of the reasons that I will name afterwards. And because this is the case, there are more opportunities to create actionable recommendations for every pregnancy-related deaths, including optimizing postpartum care. And so through the American College of OBGYN, they had a few recommendations on how to do this, on how to continuously provide this care. And so their first recommendation was to optimize the health of women and infants. Postpartum care should become an ongoing process rather than a single 1 week, one-time 6 week postpartum visit with services and support tailored to each woman's individual needs. All women should ideally have contact with maternal care providers within the first 3 weeks postpartum. This initial assessment should be followed up with ongoing care as needed, concluded with a comprehensive postpartum visit no later than 12 weeks after birth. And so this can look different depending on the different communities, but phone calls, telehealth, there are many other options besides in-person visits to create this consistent and ongoing contact with your provider. And lastly, home visits are provided in some settings. However, currently most women in the United States must independently navigate the postpartum transition until the traditional postpartum visit. This lack of attention to maternal health needs is of particular concern given that more than one half of pregnancy-related deaths occur after the birth of the infant. And so with some of the suggestions that we will talk about a little later on, there are ways to combat some of these issues and to continuously listen to some of these ACOG recommendations. Okay, and how do we do this? We can do this through one tactic is the community midwifery model. And higher level of, and so the community midwifery model meets the World Health Organization guidelines, they exceed the ACOG recommendations, and they have the resources to create this continuous and ongoing care. And so there are many key elements of the midwifery postpartum care, including that continuity of care, creating relationships with the birthing person, their family, their infants, and being a member of the community as a trustworthy and welcoming figure in this birthing person's transition from into motherhood after childbirth. And yes. Okay, and so the next one is the doula model. And as of March 1st, 2024, all New York State Medicaid members are eligible to receive doula services during pregnancy and up to 12 months afterwards, regardless of their pregnancy outcomes. And so this matters because Expectant mothers matched with a doula had better birth outcomes and were 2 times less likely to experience birth complication. They also may reduce the anxiety-related risk of developing PTSD and can also assist in overcoming medical conditions that might follow child's birth. And then lastly, studies show that women receiving Medicaid with doula support across 3 states in the United States found an overall almost 53% decrease in the risk of C-sections and a 58% decrease in the rates of postpartum depression or anxiety versus those without third-party care. So clearly through these statistics, through this research, the community midwifery model as well as the doula model are solutions to creating that ongoing care. Okay, and then lastly, a few recommendations for New York State policy. Recommendation number 1 is establishing the continuity of care during discharge and providing local resources, educational tools, and a birthing kit to each person during discharge from the hospital. And utilizing this large postpartum transition of care will provide birthing communities with direct access to care after delivery prior to even leaving the hospital. There are methods to facilitate this transitional care, including scheduling timely blood pressure checks and postpartum visits while still being at the hospital, assessing transportation and childcare needs, and optimizing any previous medical or obstetric conditions that will create this continuity of care and provide reassurance to both the patient and the infant. And through this, you can provide a thorough birth kit during or after the hospital stay, which can include anything between formula, diapers, clothing, to ensure that the birthing person has access to all of these tools for their infant. And this can be obtained in many ways, but one of them is baby to baby, which directly connects these birthing people with the resources to properly take care of their infant. And then realistically, the second recommendation is lactation consultants should be available at every hospital or birthing center. The health benefits for birthing people and infants who initiate breastfeeding for a longer period of time are drastic compared to those who are unable or don't know where to begin. Minority birthing people are disproportionately affected by adverse health outcomes, which may improve with breastfeeding. Studies show that longer breastfeeding duration has been associated with reduced incidence of gestational diabetes and may reduce the mother's risk of hypertension and cardiovascular diseases, all of the things that can play into those maternal mortality deaths that we talked about earlier. And Black birthing people continue to have the lowest rate of breastfeeding initiation and continuing at 6 months, 12 months, and providing those resources from the beginning will lower that chronic health condition risk in the birthing community. And then lastly, providing access to these postpartum support groups and home services, such as Healthy Families New York State and the Family Support Group to ensure a smooth transition from the hospital. All of these resources already exist. They've already been established within the community. But with the lack of consistency throughout each hospital and during each discharge period, it is difficult to know even where to look, even to begin to ask for help. And so creating this continuity of care during this largest transition period will create this ongoing and accessible care. And then the second recommendation, which I'm sure most of you are probably very familiar with, is the benefits of community healthcare workers and how the New York Health Foundation's primary care initiative attempts to strengthen primary care through addressing the workforce shortages. And one of that is through creating and funding community healthcare workers within the primary care field. And so by trying to expand non-clinical workforce, and through people who are often the members of the communities that they serve, doing so will improve equitable care and patient health outcomes and reduce the strain on providers. And so I believe that this approach can be adapted, this approach can be adapted for rural communities and more specifically can create standardized training and modules for rural maternal health and more specifically postpartum care to create that ongoing and accessible care for the birthing people and yeah, etc. And so with the access to midwives, doulas, nurses, or any professional in this setting, they can become, with the correct standardized training and modules, they can become the community healthcare worker and help bridge the gap between the support that's out there and the birthing person. Okay, so in conclusion, today we highlighted the role and importance of postpartum care in rural maternal health. We identified and understood the health risks that rural people face. We highlighted and understood proper and ongoing postpartum care that's crucial to prepare for long-term health and well-being. And lastly, we discovered some New York State policy recommendations to support birthing people in this postpartum period. Awesome. Thank you. I guess I'll stop sharing my screen now.
Yeah, so feel free to drop something in the chat or use a hand raise function if you have any questions or feedback for Ava as she moves through this process. As she mentioned, she was part of a 10-week internship here at NYSAR. We were thrilled to have her, and she did a wonderful job reaching out to a lot of community partners, some of which I see here on the phone today. So thank you for supporting her. Oh, thank you, Annette. So any questions for Ava or any comments again for her that might improve her output? And she, as I mentioned in the chat, she will be presenting on this at our poster session at NYSAR Symposium Conference.
Yes, I can also put my email in the chat if you guys feel like I mentioned before, if you think I missed anything, if you think there's anything I should include. Yeah, I'll just dropped it right there. So awesome.
We'll slides in. So Liz, we will be sharing the recording. As long as Ava's fine with her slides being sent out, we're happy to include those as well. Perfect, we will do that. I'm hearing a lot of great jobs, wonderful presentation. So maybe just some background, Ava, because when we were approached about the internship this summer, we wanted you to kind of be creative with the topic. How did you land on this particular issue?
Yeah, so I think the original pitch of this internship was talking about rural maternal health, and because I know a couple summers back there was another intern who focused on access midwives and doulas within rural maternal health. And so as I started doing my research, as I started to kind of understand rural health in general and maternal health within New York State, there were very limited um, articles, research, and kind of conversations about postpartum care and really understanding what that might look like and a comprehensive access to that care. And so I was really struck by how kind of under-researched and overlooked it was within the rural health community and how important it is to create these supportive communities as well as trying to combat this number of maternal mortality rates. And so I would think I was struck by the lack of research that was being done in this field.
Yeah, it's certainly concerning for us. And we've seen some comments too, one from Lauren, that this is timely here in St. Lawrence County as they're facing closure of the birthing units at one of their hospitals. So we are getting some questions come in. So the first one from Beth is, how much assessment is done on breastfeeding mothers as to their dietary intakes? How much access to healthy foods do they have? Did that come up in your research?
Oh, that's a great question. It did not, and I think I would love to look into that a little more. I'm more spent time on kind of hospitals and birthing people as a whole rather than their individual experiences, their dietary needs. And so I think if I continue this research, that would be a really interesting question and topic to look into because yeah, I don't know.
No, I agree. When I went to a lactation council, when my son was born, that was not a conversation we had.
Yeah, absolutely. And I do know that there are there are not in, there's lack of consistency throughout rural hospitals, but this is an opportunity that needs to be utilized a little more. There is the support out there. It's just knowing how to access it. So I do believe that that would be a really interesting question to look into specifically. Thank you for that.
All right. So Alyssa's question is, have you found any research on how to better engage pregnant and postpartum people in home visiting programs targeted at improving maternal and newborn health? We have a program in Washington County, but we find we have limited interest from the community in participating in this program.
Interesting. Awesome. Well, thank you for that. I really appreciate you reaching out and including your personal experience. I do believe that um I think knowledge to these accessible support groups are a big thing, and understanding where to look and how to look for these home visiting programs are a large issue. I do know in my research that it's difficult to create engagement and to create this um, kind of community-based care because people are so unfamiliar with these resources and these support groups. And so I do believe that normalizing them within the hospital setting as familiarizing them with providers, with nurses that are already within these groups. As I mentioned, the discharge stage of the hospital care, I think would be important to include in these support groups, as well as, yeah, just kind of spreading the word and making people aware of all of the resources that are there.
And Alyssa, I did have Ava sit down with our good friend Mark Spezio to talk about community paramedicine and how that could help improve the process as well. Okay, our next question is from Darla. What have you found about interprofessional collaboration for postpartum care? As an occupational therapist working in early intervention, we are often working with families. However, the client is the child. But often mothers go without the support they need, especially in rural regions.
I do know I did do a little research about, especially within these infant centered care type environments, creating this support for the mother and for the birthing person, maybe during the infant checkup, and creating maybe a two for one kind of checkup on both the birthing person and the infant, to create that access to care, as well as the access to, as I mentioned before, midwives, doulas, nurses, and the creating those just accessible knowledge to all of those opportunities, and creating that um, I guess joint access to care, if that makes sense.
Emma has some resources in here that we'll make sure you get as well, Eva, to take a look at. It may be worth exploring New York State Office of Mental Health, newish perinatal mental health focus, and some other resources there that we can also share.
Awesome. Thank you. That will be awesome to look into. Thank you.
Any other thoughts or questions from folks? All right, well, we had a wonderful, oh, sorry, one more question from Liz. In your research, who or what types of agencies were identified as trusted messengers? It's a great question.
I will say I did look into the Healthy Families of New York State. That's a large one, as well as um, the Family Support Group and Nurses at Home. Um, those are large organizations that provide this access to care within New York State. Um, yeah, let me think who else. This is a great question. I'm trying to think off the top of my head who else what other agencies were I utilized. Yeah, I think those were the main ones. But yeah, I appreciate your question. Thank you.
And we will be posting Ava's, she's creating an issue brief and position statement. We will also be posting this on our website when it's completed. So be sure to check it and be on the lookout for that. Liz just said she's hoping to build on this with the presence of WIC, independent doulas, and CHWs. Agreed. All right. Any other questions before we wrap it up today? This was a lively group today, so when Janiyah drops the link in the chat for review and evaluation, I really hope you guys take part in that so we can give Ava that feedback at the end of her internship. Again, thank you everybody for coming and showing up and asking wonderful questions and supporting NYSAR and our wonderful intern Ava. And we hope to see you at the symposium conference in September and our next webinar in October. So thank you so much, everyone, and have a great rest of your day.